All right, now let's talk about the drug. So hopefully by this point you've listened to the intro really quick, not a big deal. This presentation is a big deal. No, there's more important stuff here. Lots of drugs in this one that I want to make sure you guys know about. And also there's a lot of drugs just in general with this neurology module. So I want to make sure you guys are keeping things straight and categorizing them correctly. With having said that, some other textbooks, some other pharmacists, some other pharmacy resources may classify some of these drugs differently. So it's not saying that one's right or one's wrong. There's with some of these drugs, you're going to see them in other modules even from me, and I'll maybe classify them differently. So just a heads up on that. I've had students in the past come to me, and some students like other textbooks or they like other sources or whatever, and they'll be like, hey, you're calling this hypnotic, but then this other textbook is calling it what. So sedative-hypnotic, those drugs maybe have some different classifications. They also have some subcategories that I want to make sure you guys are paying attention to, and you know, note, and same thing with the anxiolytics. Those, that basically means the preface here means anxiety, anxious, and then lytic or lysis means to cut. So these are anti-anxiety medications, which is another label that you may see. And it's honestly the label I say. I usually say anti-anxiety or a lot of times too, I'll even say anxiety medications. And the thing is that they're not medications that you're giving to give a person anxiety. It's that they are helping to treat the anxiety. So they're anti-anxiety or anxiolytic medications. So let's get into it. Basic properties here. Big thing here for this whole presentation. It's kind of like you guys remember in the immunology, hematology module, bleeding was a big adverse effect. So with this lecture in particular, with these drugs that we're going to talk about today, I want you guys to know, or rather link all of these drugs with CNS depression. So CNS depression. Basically, drowsiness, dizziness, fogginess of the brain. There's different specific adverse effects, and there's different ways to describe those adverse effects, or to elucidate the way that those adverse effects maybe are affecting a person. But the take-home point, the big message, and I want you guys to know for all of these drugs, is CNS depression. So definitely put a star by that, highlight that. That's going to be a big adverse effect you have to be concerned with. And then also implications of that. So they can't operate heavy machinery. What does that mean? They can't drive their tractor for work, or the forklift operator, or even their car. In the pharmacy, a lot of times, if a patient is naive, meaning they have not taken these medications before, and they have a CNS depression warning, me and other pharmacists will warn them that they should not be driving until they know what effect the medication has on them. Because the CNS depression can vary from person to person. And so I've had patients who, I'll give them a warning and they're like, oh no, don't worry about it. Like I can, take this in the morning, whatever it is. And I don't get sleepy till like 10 at night. And there's other patients that they take it at, bedtime, and they're still drowsy the next morning. They have the hangover effect, and they still feel kind of sleepy the next day. So I know, like my grandma too, she's kind of extremely sensitive with some of these CNS depressants, where they would cause her to hallucinate and to pass out. And she doesn't drink, or she never drank or did anything or had any, other than occasionally she was prescribed things that were CNS depressants. And it was like she was super drunk and barely could walk, and we would have to, it's just like, my grandpa thought it was funny, but the rest of the family didn't think it was funny that grandma's drunk. But yeah, so anyways, she's super sensitive to these. So that can also just depends on your patient. Kind of related to that too, there is an issue with some of these drugs with tolerance and physical dependence. So there's psychological dependence and physical dependence. And so we'll talk more about that in the psych module, this psychiatric module. But definitely note that some of these can have tolerance. And tolerance basically just means that you need to take more to have the desired effect, right? So your body basically adapts to a certain dosage, let's say, of a CNS depressant, and so that the intolerance builds up. So anyway, so there's some implications there. The other thing too to note is that and this last bullet point has confused some students. So barbiturates and benzodiazepines both cause CNS depression, and they both are its concern. Just relatively speaking, the barbiturates, it's a bigger issue, and they can cause complete CNS depression, where the benzodiazepines do not. However, you still need to be concerned with the benzodiazepines and their CNS depression. potential. So make sure you guys note that. So CNS, again, CNS depression for all of these drugs we're going to be talking about. It just varies from agent to agent or from medication to medication. So here's a list of the ones that you guys are responsible for. These are all the generic names of these. Kinetics, this one, it's just a general FYI, but just know that a lot of these go through the liver, and you have to be thinking about the implications of the liver. Oh, and the other thing I've remembered, and I forgot, and that's why I paused it, but okay, now I remember. One sec, let me go back. The other thing I wanted to mention too on this slide is that with the CNS depression, there is lots of potential for synergy. You guys remember that from previous modules, so synergistic effects. So with these CNS depressions in combination, the effects can be more pronounced, or there's more of an issue with it. So that's another thing to think about for drug interactions. And that's also concerned for people, especially in countries or cultures where they consume alcohol recreationally. So with these CNS depressions, depressant drugs being combined with alcohol, it can be a more pronounced effect. So a lot of the prescriptions we fill that are CNS depression, we warn against not taking with alcohol. So, and like I've said before, that can mean something like some cough syrups have alcohol, some desserts have alcohol in them. It just, some mouthwashes have alcohol in it. So it's not necessarily for your patients who drink a lot. I mean, those, of course, you'd want them to warn them. But yeah, so the synergistic effects, CNS depressants and combinations, definitely something you'll see test questions and board questions and stuff on that. So that's what I forgot. Jumping back, sorry, a little scatterbrained here. Kinetics, FYI, don't worry too much about it. The half-life, again, can vary. It's going to depend on the product here. The liver's involved with a lot of the metabolism, so that's going to have some implications too, and have some potential for adverse effects, toxicities. All right, so mechanism of action. For all these sedative hypnotics, we want to be thinking about GABA and its effect on the GABA receptors. So here is a good representation of that visually, but basically we have the benzodiazepine here, for example, binding, and it encouraging the GABA to bind to the GABA receptor, which opens the chloride flux, or rather the chloride channel to open and have an increase in chloride flux. So I didn't say that super great, but just to recap, and hopefully it's said in a better way, that these benzodiazepines, for example, or these sedative hypnotics bind to stereospecific benzodiazepine receptors on the postsynaptic GABA neuron throughout the CNS, the central nervous system, and then this basically causes the chloride flux to happen, which then causes a hyperpolarization, a stabilization, and so that this is what all the effects of the medication, so the sedation and hypnotic effects, appear to be linked to these GABA receptors. So take-home point, I know I said a lot and I kind of stumbled around, sorry about that, but take-home point here is that they basically work on the GABA receptors. So you can put a star by that. That's going to be the big take-home point for testing purposes and for mechanism of action, etc. And then secondary to that is that they facilitate the chloride flux. And then that causes all the sedation and hypnotic effects that we get because of its effect on the CNS, basically. So related to that, its uses here, we have a whole bunch. Go ahead and read through those. And we're going to talk about some of these more in detail and some drugs specifically for certain things, but just go ahead and read through that. And again, you will see these in other modules too. So we're seeing it here, neurology is related, but then, muscle relaxants, we're going to see in the musculoskeletal module, anxiety relief, we're going to see that in the psych module too. So this is just a general overview here. Don't stress too much about this slide. Students in the past sometimes have gotten confused about this slide. The point of this slide is just to show you that for the class, there's a lot of different things to think about. There's a lot of different modules, so to speak, to think about. And so that's the point of it. Don't stress too much about this. I have almost taken this slide out, but I decided to leave it in because it reminds me to tell you guys this is supposed to sort of help you show that you sometimes need to connect the dots as far as in between modules. You will be seeing these drugs in some few modules. Adverse effects. This is a good slide to pay attention to. I would would study this one. Definitely put a star by this, especially the drowsiness. Put a big star by that. I already talked about CNS depression. Put a star by that. Toxicity, just in general. Unfortunately, some of these drugs are abused. There is a physical dependence that I mentioned. There can also be a psychological dependence. And so some of these drugs are drugs of abuse. They're used by themselves or in combination with other drugs. So Xanax is one. I know that's popular with the kids these days now. But there's, unfortunately, young adults will, and some teenagers and stuff will abuse Xanax, which is a benzodiazepine. It's alprazolam is the generic name. It's brand name. And so, unfortunately, there is an issue with abuse, and then that can lead to toxicity. And performance and judgment, I also talked about that too, just with the CNS depression. So definitely note that. And again, classic board question. It'll be a forklift operator or some farm worker who's driving a tractor. And then you need to know that these drugs, so benzodiazepine, for example, or barbiturate, causes CNS depression. And then what are the implications of that? Overdose, go ahead and look at that and make sure you know the signs or the symptoms there that can happen with overdose. Treatment of overdose. This one, go ahead and read through this. As far as testing purposes for me, go ahead and put a star right here. I want you guys to know this as the antidote for a benzodiazepine overdose. This is Flumazenil. So definitely highlight that, star that. The other things are important. Definitely don't get me wrong. I'm not going to say that they're not important, but for testing purposes for me, the rest of the stuff may be beneficial for ICM or maybe some of your other courses. Here we have some cautions that you can think about with the drug. So the porphyria or the family history of that may be a problem, specifically the barbiturates. That's just one of those rare but serious things that can occur there. It's not super common. Hepatic and renal insufficiencies, most of the time is going to require a reduced dose. So that's where you have to think about these drugs, and you need to be thinking about their kidneys and liver when you're dosing these. And then I mentioned again, additive effects, synergistic effects, definitely. And then that includes alcohol. So definitely something to be thinking about. Put a star by that. I already, I think, highlighted that enough for you guys. Now going into the specifics here, benzodiazepines versus barbiturates. This is just an FYI. Don't stress too much about this slide. This is just kind of showing how earlier I talked about the barbiturates can cause a complete CNS depression, which is you'll see up here as death, versus the benzodiazepines. The dose response curve is a little bit different, but this has confused students in the past, and it's where they have thought, oh, benzodiazepines aren't as bad, or so relatively speaking, they are relatively safer, and they are relatively, they do have, relatively speaking, less CNS depression, but you still need to be concerned with CNS depression with it. So, and you'll see that with some of the uses and stuff. And then too, just note with benzodiazepine, it depends on how you give it to. So IV, you actually can have more anesthesia effects and get some respiratory depression. You typically don't get that with PO administration. But I'm hesitant on my language a little bit just because, unfortunately, people still will overdose on benzodiazepines. A lot of times it's not just because they're just taking benzodiazepines. It's in combination with some other things. So I know benzodiazepines and opioids are a big issue now, and that can be problematic. So even with PO administration of benzodiazepines, it's not that specifically the PO administration is causing the respiratory depression, but there's other medications like an opioid that is causing respiratory depression. And then the benzodiazepines are also causing the other CNS depression, et cetera. And so it can still be problematic. So don't let this table confuse you too much. And again, the benzodiazepine versus barbiturates, this is more kind of pharmacist stuff, I guess, as far as the dose response curves. I don't give you guys a lot of these in PA school, but it's just here, it can show up on board questions and stuff. So, but just know that it's a relative, like we're just squinting and just looking at benzodiazepines versus barbiturates. We're not talking about benzodiazepines versus like Tylenol or something, right? So Tylenol pretty much causes no, acetaminophen is a generic of Tylenol, pretty much causes no sedation, right? It's pretty much non-existent. And then benzodiazepines cause a lot of CNS depression in comparison. So hopefully that's clear. If not, just email me. So every year is usually a student or two that wants a little bit more clarification on that. No big deal. Again, too, one of the advantages, especially of PO benzodiazepines, is you don't have to be as concerned with the respiratory depression. So that can be something. This is another one that's, again, is technically correct. The second bullet point, I hesitate to keep it in there and I don't really like it. But so again, when you're comparing benzodiazepines to barbiturates, there is a less of a chance of dependence and abuse, right? So the barbiturates you don't really see anymore. They're still out there and they're still prescribed, and you will see them every once in a while, but for the most part, their benzodiazepines are used a lot more because they have similar uses and stuff. But so the barbiturates were a lot more addictive than the benzodiazepines. However, the benzodiazepines are still addictive, and there are unfortunately still problems with abuse. And there is abuse potential. So that is something you'd be thinking about. And definitely relevant for PAs because you guys, benzodiazepines are a controlled substance, but they are a controlled substance that you guys can prescribe. So you guys are not allowed to prescribe C2s in Texas, right? But in the state of Texas, but these have a less strict. So C1 is the highest strictness of a controlled substance. C2 is the second highest. But these are 3s, 4s, 5s. It's as far as their controlled status goes. And I'll give a formal presentation later about control status, so about prescription control status. So don't stress too much about that, other than knowing that you guys will have prescribing privileges or prescribing right with the DEA license, which is something you'll register for once you graduate. You will be able to prescribe these benzodiazepines, and so that's why I spent a little more time and want to make sure you guys know that there still is a risk, and unfortunately, it is something that still is abused by some of your future patients. Kinetics. Don't stress too much about this. This is, again, just kind of FYI. I don't test you guys on this kinetics. Duration of action. This one I do want you guys to know about. So put a star by here. I definitely want you guys to know which ones are short acting, which ones are intermediate, and which ones are long acting. So these are benzodiazepines. If you want to put benzodiazepines on the top, there was one student last year who was kind of funny. She and I would joke a lot, but she kind of confronted me. She's like, why don't you put that on the top? Why don't you just write that on the top? And of course I keep forgetting. And I'm like, yeah, I'm going to do it. But anyway, so these are all benzodiazepines. So you can go back, and because I told her my smart response was, hey, it's on the table right here. But so benzodiazepines, just so everyone's on the same page. It's funny, some of the things you guys will say and do or email me or whatever, and it's just like I always will have an association with one student and one thing. But anyway, so benzodiazepines for that last student last year. But yes, so please put a star here. Guaranteed test questions here. I want you guys to know the difference. And it's not just because I like to torture you guys and make you guys memorize random stuff. It's because this will help you when you're prescribing, when you're choosing drugs. And because certain drugs, depending on the duration of action, it dictates how and when they're used, how you dose them, how frequently you dose them, etc. So go ahead and please memorize the duration of action for these. Mechanism of actions, we talked about these already just in general terms, but these specifically hit the GABA A receptor. They do not hit GABA B. Okay, so specifically GABA A subtype, important to note. And then again, they have the effect on the chloride influx, so chloride channels are affected, and then they cause all their effects, sedation, help with seizures, etc. So take home point, GABA A for benzodiazepines, and then affecting that influx of the chloride channels, right? Of influx of chloride, and causes the hyperpolarization. And the implications of that, by the way, so that I'm talking about the hyperpolarization in a cell wall. So with the hyperpolarization, you have a less excitable state and you have stabilization. And so that's where you get the sedation and the CNS depression, basically. But please here, just put a box around that, star that, GABA A, benzodiazepines. Uses. So we mentioned all the general uses there, so go back to refer to those. But also, you will see these used for certain seizure disorders. Not super common, and not everybody that has seizures. It'll just kind of, you guys will hopefully learn in ICM, I believe, what the nuances of the seizures, I guess I should say. So because treating seizures can be kind of difficult, or there's sort of an art to treating seizures, I should say. But just know that part of your toolbox, so to speak, is that you can use these benzodiazepines and they can be used for that. Alcohol withdrawal is another one. So use this a lot. Use benzodiazepines a lot in the at the psych hospital I worked at in San Antonio. So they did a lot of alcohol and drug detox. So then they're a part of protocols. You'll see these in other protocols too, though. The hospital my wife's at right now, there are specific detox protocols, and they have lorazepam on them as well. So which is a type of benzodiazepine. So you'll see these in hospitals too. Even if you're not at a psych hospital, they'll use these for certain alcohol withdrawal or some certain detoxes. Adverse effect. Make sure I want you guys to know all these. Physical dependence, again, I mentioned is an issue, addiction and stuff, but go ahead and read through all of these. And then withdrawal symptoms too, go ahead and look at that too. I want to make sure you guys know that a person can have withdrawal symptoms and they usually will have to be tapered off and or monitored if they're on high doses for a long time. Antagonist here. Want to make sure you guys know this. Put a star by here, box there. Want to make sure you guys know for toxicology purposes, the Flumazenil, see it on board questions, etc. And just a note too, you want to make sure you are giving it for benzodiazepine overdose because they unfortunately can cause seizures if a person's not overdosing on the benzodiazepine. So that's just something that you have to monitor for. But it's usually not a huge issue because if a person has an overdose, they typically are in a hospital or some sort of ER, emergency department, hospital setting. So you can treat and monitor their seizures there too. So then we have the benzodiazepine agonist. So this is a subset of for categorization. These, you have to have much higher doses to have the muscle relaxation and anti-convulsive effects. So these are not usually prescribed for those things. These are mainly used for sleep aids or for insomnia. But then note too that because of their mechanism of action is similar enough to the benzodiazepines, they can have their effects reversed by the Flumazenil as well. So these are things that you probably or may be familiar with. They're not over the counter. I was gonna say they're advertised a lot. They're popular. So Zolpidem, this is a generic for Ambien. So this is used for, it's short-term, it should be short-term treatment of insomnia. So that's what the FDA approval is there, but I do see it being prescribed and it's used longer term. I'm gonna have a specific separate presentation about insomnia. So we'll talk about these drugs more, but I just want to make sure you guys know where they're categorized and how they're we have Zaloplan here, or the brand name is Sanada. This is another one that you may have seen the TV commercials for, and we will be talking about more in detail in that insomnia presentation, but it's also used for short-term treatment of insomnia. This is a generic for Lunesta. It's Zopiclone. Lunesta to me is a lot easier to say than a Zopiclone. But anyways, another one that is used for insomnia. Barbiturates. And like I said, we'll also talk about that more in the insomnia lecture. Barbiturates, like I said, they're down here. Historically used more. They were a lot more popular than they are now. But you still see them. I still will dispense them every once in a while. And then too, depending on, it just kind of depends on where you guys end up working, which practice setting, etc. Kinetics, don't stress too much about this. Just FYI, I'm not going to test you guys on that stuff. Again, put a star by here. So this is for barbiturates. Again, sorry, student of mine in the past. If you want to put on the table there, because I'm too lazy to. No, if you could put barbiturate, if that helps you study. But these are barbiturates. And I want you guys to know which ones are ultra short, intermediate, and a long acting. So guaranteed test question on that too. Or about that, or whatever. You know what I mean? Yes, put a star by this slide. Mechanism of action here. So similar in that they affect GABA. So similar to the benzodiazepines in that the GABA is involved. But these have sedative, hypnotic, and anticonvulsant properties. Again, like the benzodiazepines. These actually depress the sensory cortex, and they'll decrease motor activity. alter cerebral function and will definitely produce drowsiness. So that's something you have to think about. Sedation too, and then hypnosis. So yeah, then they also too note on here, I mentioned before, but they have dose-dependent respiratory depression that can be an issue, and that's something you want to think about. So, and here's some uses there. I talked about it there just in a little bit, but low and high doses, again, depending on how you're dosing and how frequent you're giving it, also depends on the duration of action, which is why I want you guys to remember that. Drug interactions there, put a star by that. Anytime you see barbiturates, I want you guys to be thinking about drug interactions because they go through the P450 system. So, again, for testing purposes, board questions, etc. Anytime you see someone on a barbiturate, just double check or think about drug interactions. And then also too, with the CNS depression, definitely always think about other medications that can cause CNS depression. So it's not technically a drug interaction, but I kind of think of it as the same, as similar to a drug interaction because you have two different drugs that can cause sedation. Other sedative hypnotics. So again, these are ones that, depending on what textbook you use or where you're looking, they may be in other categories, but for my test purposes, please just keep them in my categories that I give you. Buspirone. So this is Buspar is the brand name of this one. This is a partial agonist of serotonin receptors, specifically 1A receptors in the brain. And these are help treat anxiety, so anti-anxiety medication. They will not have any anticonvulsant, hypnotic, or muscle-relaxant properties. So these do have a lot less sedation that you have to be concerned with. So just my personal experience, the majority of patients I've dispensed these to say that they don't have problems with sedation, but it is a potential there. There is something, that it could cause sedation, and maybe I just happened to dispense to the ones that didn't have any sedation, but you still can have some sedation. But it's less than the other. It's definitely less than benzodiazepines and less than the barbiturates. But something to still be concerned with. And again, if a patient's naive or they've never taken it before, something that you'd want to warn them about. And then still, if they have a combination of other things, not an issue as far as drug abuse is concerned. This is one that's typically not a concern with drug abuse. So no evidence of tolerance, rainbow anxiety, or withdrawal of drugs. The cross tolerance of benzodiazepines, you have to be worried about drug abuse or additive effects. So it's not like adding a barbiturate to a benzodiazepine or a benzodiazepine with alcohol. Just the sedation maybe, but it's one of those rare ones that you don't have to be too concerned about. Chloral hydrate. So this one is used usually by anesthesiologists, or it's not really popular, but the only place I've actually seen, honestly, is in the psych hospital. They would use it for people who got the electroconversion shock therapy. Is the only time I ever saw it being used. But just kind of, no, it's still around. But you know what? I forgot after I said it's not still around. Okay, so it's no longer available in the U.S. So this is when I worked in the psych hospital, was a few years back. So last few years or whatever, it's been pulled off the market in the U.S. So sorry about that. So don't worry about this drug. Not that big a deal. Just there for historical purposes. It won't be on the test. But yeah, this one is no longer available. This one is around, but it's still not. It's also not very popular. It's an anti-anxiety medication. It can be used for anxiety disorders, but there are limitations of use. It's not preferred for treatment option for anxiety disorders as per the American Psychiatric Association, the World Federation of Societies of Biological Psychiatry, and the British Association of Psychopharmacology guidelines. So no one recommends its use, and so it is still available generically. I think, I only filled this at the psych hospital that I worked at, and maybe like once or twice the whole time I was there. Not something that is really popular or that you will probably be seeing. So you may only, if you work with a psychiatrist, that may be the only time you prescribe this, or at a psych hospital every once in a while. Propranolol, this is one we talked about already. It's a beta blocker, but it can be used for performance anxiety. So the classic example is someone who's, or like, I feel like in the board questions, or whatever, it's always someone who's like a professional violinist or something. I don't know. And it's like they have to, that's the setting in the board question. And it's like, you give them propranolol. So that's just something, even though it definitely, helps lower blood pressure. It can also be used for the performance anxiety. Remeltion, another one that can be used for insomnia, which we'll talk about its specific uses. But this one hits the melatonin receptors for mechanism of action there. Ethanol, which you guys are maybe familiar with, maybe not. I don't know. If you're over 21, you can legally enjoy this here in the U.S. And if you're not, don't drink it. No. But anyways, it's still important. It's popular culturally here in the U.S., so a lot of your patients will probably either occasionally or regularly drink, so that's why it's in here. It's also a CNS depressant, right? Just go ahead and read through this. Don't worry about that too much. Mechanism of action, again, potentially the action of the GABA receptors, and so it's CNS depressant. And like I said too, you have to be concerned with this with other drugs that are CNS depressants. Adverse effects, definitely pay attention to these, look at these, go through all of these and make sure you know all of these for testing purposes. So put a star by there. I want to make sure you guys know the adverse effects of alcohol. Some of these you might be familiar with or learned in other classes, but just again, read through these. Want you to make sure. And in particular too, you need to be concerned with the liver. It will be toxic to the liver, especially long term at higher doses. So that's something to think about. But go through all these. Nutritional deficiency is another one too that students don't a lot of times think about. But so when a person does ingest alcohol for a long period of time, they will need vitamin supplementation. So that'll be part of your regimen too. So those are things that in the past students have missed. But go ahead and look through all of those too. Thiamine is important too. So make sure, again, put a star by this. Make sure you really squint at this, look at this for testing purposes. And for your patient population too. It'll be good for them too. More adverse effects. So again, put a star by here too. Want you guys to make sure you know all the adverse effects for testing purposes. Also, there are teratogenic effects. So pregnancy category there. Put a star by that. Want you to highlight that. Not something that they recommend pregnant women to take. I have heard, you do hear out in lay public or, family, friends, movies that it's okay to drink a little bit. So when you're pregnant, and so maybe, technically speaking, yes, maybe it is, and your body can safely clear the alcohol. But for healthcare provider, textbook answer for any of your patients and for yourselves and for testing purposes for my class, it's no, avoid alcohol. Do not take it because the amount of alcohol can vary from woman to woman as far as if there's going to be a negative effect on the fetus. And so as a healthcare practitioner, you just say no alcohol at all. Don't say, oh, is it okay to just occasionally have a glass of wine? Because, and actually one of my grandmas is one of the people that she's always like yelling at people like, you can have like a glass of wine one time when you're pregnant. It's not that big a deal. But, because that was kind of old school back in the day. She's like, when I was growing up and in my country, she's from the Dominican Republic. In my country, pregnant women, you can have one glass of wine one time or whatever, once a month or something. It's not that big a deal. And yeah, maybe technically it's not. And luckily, none of my family members had it. The fetal alcohol syndrome. Thank you. Knock on wood. She didn't drink that much. And she maybe only did have like a glass of wine or whatever. But yeah, definitely for testing purposes, for board questions, and then for your future patients, just avoid no alcohol when you're pregnant. Drug interactions. So this is another one to put a star by that is important to know. There is a medication called disulfiram that was developed as the generic for, it's called Antabuse, and this was developed to help treat alcoholism. And this is a drug that inhibits the enzyme that actually breaks down alcohol, and then you have a toxic, horrible reaction. There are some other drugs that have a disulfiram-like effect. So we mentioned metronidazole before. That's the generic for Flagyl. And then here's some other ones too, some cephalosporins as well, where you have a really bad reaction if you ingest alcohol. And then again, cough syrups, mouthwash, etc., certain desserts, whatever. And then there is an instance where that you do have to be concerned with alcohol and drug interactions because acutely alcohol actually suppresses the P450 system, and then chronic alcohol enhances the P450 system. Which can be a big concern for drug interactions. So I want to make sure you put a star for that. Specifically acetaminophen, which is generic Tylenol. So with chronic alcohol consumption, you have an increased risk of Tylenol causing hepatotoxicity. So with alcohol, especially depending on your patient and how much they drink and how frequently and how long they've been drinking, you need to be thinking about drug interactions with the alcohol. Methanol, this one, again, is unfortunately sometimes ingested. It's typically not on purpose, I don't know. But intoxicated patients can also be treated with ethanol or fomepizole, so put a star by that. I want you guys to know that. I want to make sure you know the antidote there. Ethylene glycol, antifreeze. Again, just read through this, adverse effects. Related to toxicology, you guys get toxicology questions on your boards, but so put a star by here, ethanol or fomepizole. Want you guys to know the antidotes for those for testing purposes for my class. And we also too we do have a toxicology section of formal toxicology. So you'll be seeing these again and seeing test questions on them again. And part of it's because I believe in repetition, or that repetition helps learning. And again, like classic board questions, they always do these toxicology things. So that is it for this presentation. As always, email me if you have any questions or anything was confusing or I don't know, didn't make sense or whatever. That would be great. And by the way, too, it's email me directly and don't go through the course messages on Blackboard. I mean, you can go through course messages on Blackboard, but I will reply quicker to the email if you have questions. Thank you guys for your time and attention. I will talk to you guys later.